Hello and welcome everybody to tonight's webinar on pelvic pain, brought to you by Capital Health Network and a multidisciplinary team of hardworking women's health experts. Firstly, I would like to acknowledge the traditional custodians of the land which we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. Tonight's webinar focuses on pelvic pain. I'm Michaela DeLeva, a physiotherapist and Quality Improvement Project Officer at Capital Health Network. Also with me tonight is Dr. Tara Frommer from Sexual Health and Family Planning ACT, Women's Health Physiotherapist Emma Bowen, and of course, Kanal Mahiti, the events lead here at Capital Health Network. Before we jump into things, I'm just going to run through some housekeeping for the night. All participants in the Zoom have been muted. Please address any questions that you might have in the Q&A section of the Zoom meeting, not in the chat box of the side panel of your Zoom window. We'll have a question and answer session after both Tara and Emma have presented. The presentation itself will be uploaded to the CHN YouTube page, and you're welcome to share this with your networks. In regards to CPD, please fill in the post-event evaluation survey, which you'll receive in the coming days after the webinar. CHM will email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home for tonight's event. Just before we jump into things, I would also like to highlight the Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including pelvic pathologies. The login for Health Pathways is together, and the password is for health, all one word. Health Pathways are a reliable source of up-to-date clinical and referral information that has been localized to our area. Your feedback on the pathways is invaluable to keep them updated and reflective of our local health environment. So we encourage you to locate the feedback tab at the bottom of each pathway page and provide any feedback that you might have. Our first speaker joining us tonight is Dr. Tara Frommer. Tara is a GP with a special interest in women's health. She is a senior medical officer at Sexual Health and Family Planning ACT, and is the clinical lead for the new SHFP ACT Pelvic Pain Clinic. She splits her time between doing this and working in general practice. Please join me in welcoming Tara.
Thanks for that, Michaela. Give me a moment and I'll just get my screen to hopefully start sharing. Oh, sorry. Start sharing at the start. Okay, well, thanks for everyone for coming. Today I'm going to be talking about pelvic pain management for GPs. And for today, I will be focusing on pelvic pain in patients who have been assigned female at birth. And for ease of this talk, I will be referring to these patients as women. However, I would like to acknowledge that whilst outside the scope of our talk today, pelvic pain in male patients and our gender diverse community is also a significant issue.
Tara, we cannot see your screen, by the way. You haven't shared it.
Sorry, I'll come back then. Apologies, guys. I'll start again.
Yeah, we can see the screen now. Perfect. Thank you.
And you've got the right one up?
Yeah, pelvic pain.
Awesome.
GPs. Thank you.
Thank you. So this is a little bit of an outline on what I'll be talking about. We'll be discussing what is pelvic pain, when is dysmenorrhea abnormal, and then focusing in on the role of the GP in pelvic pain. So what is pelvic pain? Pelvic pain can be described as abdominal pain located below the level of the umbilicus, including frequently lower back pain with or without radiation to the thighs. So pelvic pain can have many definitions with potentially many organs being involved. And it can have many different components, including painful periods, vulvovaginal pain, pelvic floor muscle dysfunction, irritable bowel syndrome, etc. Chronic pelvic pain can be defined as pain in the area of the pelvis that is present on most days for more than 6 months. And my only addition to this is that women are pretty tough, and they will often only tell you about that 1 week that had their worst pain. But often if you question a bit further, in reality, they're experiencing some level of pain or discomfort on many more days than they're actually disclosing. And so these are the broad systems that are often involved in pelvic pain. And these are some of the conditions that might be associated in your patients that are presenting to you with pelvic pain. As you can see, there are a lot of them, so a lot of things to think about. I'd like to start off talking about a case study, and we'll call this patient Bella. So she's a 16-year-old female presenting with painful periods. Her periods first started at 13, and they've always been regular, painful, and heavy. She has tried proactive use of Ponstan, so taking it 3 times a day at the first onset of pain. And that did help a bit at first, but the pain has since worsened. She was started by one of your colleagues on the combined pill in the form of Femtab 20. And she did use this for 3 months, but found she was getting a lot of breakthrough bleeding and still a lot of pain, so she stopped it. However, now the pain is continuing to worsen, and she's now missing about 1 to 3 days of school every month because of her pain. And so obviously Bella has pretty significant painful periods. And my question to the audience is, do we think that Bella might have underlying endometriosis? And if so, what do we think we should do about it? So Kunal, if we can put up the first poll. No, hello.
Yeah, launching it now.
So if everyone can have a look on their poll, I'd love you guys to hear what would your initial approach to a patient, maybe like Bella or someone else that you suspected had underlying endometriosis. And I'll give everyone a couple of minutes. Okay, so that's probably, oh, no, we've got a couple of last minute ones. We've got almost everyone now. I'll give it 10 more seconds. And hopefully now everyone should see the answers. And we've got a really good variety in answers from our audience, which I think is a really good representation of the fact that we have a lot of different skill sets in here, And there isn't actually a right answer to that question, but it gives me a really good idea of how comfortable everyone in the audience is feeling when they think about a patient with endometriosis. So the question is, when are painful periods abnormal? We know that actually the rate of painful periods in adolescence is actually quite high as 91%. And we know about a third of female adolescents experience severe dysmenorrhea. We also know that dysmenorrhea has significant impacts on function, including school attendance, and also significant impacts on quality of life. And that really makes sense, particularly now that we have started to understand more about the impact of stress and trauma on the developing brain. It's pretty unsurprising that the literature shows that dysmenorrhea is associated with mood disorders and chronic pain, and that it's also associated with central nervous system sensitization. As a result of this, sometimes I do find it actually helpful to think of severe dysmenorrhea as a diagnosis in its own right. And I find sometimes it's quite helpful for patients to conceptualize their pain as well. So if we do think we need to investigate for endometriosis, the question is, when should we do that and how should we do that? Currently, the gold standard for diagnosis of endometriosis continues to be laparoscopy, and this continues to be the only way we can definitively rule out endometriosis. However, over the last decade or so, specialised endometriosis ultrasound has become another valid tool. And of note, we have 2 locations in Canberra currently offering this imaging modality, and that's Canberra Fetal Assessment Centre and Unique Imaging. There are also lots of Sydney-based options. MRI is an emerging imaging technique, but still doesn't have a good evidence base in the diagnosis space. So like I said, diagnostic laparoscopy continues to be the gold standard for diagnosis of endometriosis. However, we know that no surgery is without risk, and particularly in this population where we already worry about potential fertility issues, we already know that previous surgeries can potentially affect ovarian reserve, and also the effectiveness of assistive reproductive technologies. And we also know that when we're talking about surgery for fertility and endometriosis, it's that first surgery that is most effective. And so if we think about a patient like Bella, who's obviously only 16, having her first surgery be a diagnostic laparoscopy at 16 is potentially going to have impacts on her fertility down the track. So there is a big movement to move away from laparoscopies for diagnosis only and aiming for good quality surgeries with advanced laparoscopic surgeons to both diagnose and treat endometriosis at the same time. Specialised ultrasound has become much more prominent and available in the last decade. And we know that it has pretty reasonable sensitivity and specificity for deep endometriosis, with some studies quoting over 90% sensitivity for deep endometriosis. But we know it's very user dependent, and it's still not great at picking up superficial endometriosis. However, it is less invasive and less risk than surgery, and it can also be useful sometimes in surgical planning. It can be a really validating study, however, only for our patients that it is positive for endometriosis. It's relevant to consider that mostly this study is still performed with a transvaginal probe, so it's still quite invasive for patients, and particularly for our pelvic pain patients, it's often quite painful and quite distressing. And it also can encourage a patient to focus on a model where pain equals damage to organs. And particularly for our GPs in the audience, We know how problematic this can be, you know, when we're talking about back pain or knee osteoarthritis, how damaging that pain equals damage message can be. A similar thing can happen in pelvic pain as well. And so we're coming back to this, does investigation actually change our management? Kunal, can we have the second poll, please?
Yeah.
And so the second poll is asking how a diagnosis of endometriosis changes your management. And I'll give everyone a couple of minutes to answer this one too. Okay, I might end it there again, just in the interest of time, because I know it's late for everybody. And I'm just going to share it again so everyone can see it. But once again, we're getting a really good mix, which I think just reflects that we do have varying levels of confidence in this space. And again, none of these answers are wrong. Does a diagnosis of endometriosis change our management? And the answer is sometimes. So what are the benefits of early diagnosis? So we know that validation of a patient's symptoms is really, really important. We also know that early management of a patient's symptoms is important. But I guess the question is, do we need an early confirmed diagnosis of endometriosis to do these above two things? Some points to think about. Current research would suggest that up to 63% of endometriosis over a 2-year period remains stable or actually regressed. And we also know that definitive laparoscopy is rarely a cure, with rates of recurrence up to 25% at 2 years and up to 75% at 7 years. And so I guess investigations for endometriosis might not change our management if validation of the patient's symptoms can happen without that diagnosis. If symptom control can be optimized with good quality medical management. And also if we assume that actually all painful periods and pelvic pain has the potential to impact patients' lives. So I guess if the above things happen and are true, then maybe it might not change whether we have a diagnosis of endometriosis or not, particularly in our early management as a GP. So coming back to Bella, and after a long chat, you decide together with Bella and her mum not to refer her for laparoscopy at this stage. You do offer a specialised ultrasound scan referral, but you do stress that actually this is not required to manage her pain. And they're quite keen to know what are their options for managing this period pain. Now, for a patient like Bella, probably a first-line option for symptom management would be to trial menstrual cycle suppression if she's amenable to this. Now, I feel GPs are actually pretty good at menstrual cycle suppression, so I actually won't dwell too long on this slide. The only thing I will say is I actually do offer all of these options to every patient, obviously so long as there are no frank contraindications. And so I don't just tell every 13-year-old that they can only use NSAIDs, or every woman who's had a baby that the only thing that they should do is a Mirena. And I do this because everyone actually interacts with hormonal contraceptives so differently. And also because women need to be part of this decision-making process as it puts them back in the driver's seat and in control of their health. And I think particularly in a pelvic pain space, particularly in our patients who are a little bit older, they've often spent many years not feeling in control of their bodies. So any extra control that we can give them is really important. So coming back to Bella again, after all the discussion about different hormones and options, she actually decides to go back on the pill, but to increase the dose to the 30. She now understands that breakthrough bleeding is actually highest in the first 3 months, and for most people will generally settle. She plans to take the pill with a shortened hormone-free interval of only 4 days for the first 3 or 4 months, because we know that this will decrease her flow and her pain. And she will also use anti-inflammatories or tranexamic acid during that hormone-free interval to manage any period pain that she does get. And if that goes well, she plans to trial a tailored regime of taking continuous active pills to minimize her bleeding and only taking a hormone-free interval if her breakthrough bleeding is not settling. And so this is what she does. And she comes back to see you after a year for a new pill script. And she's super happy. She's been taking active pills continuously and only taking that 4-day hormone-free interval if she gets more than 4 or 5 days of breakthrough bleeding. But actually, for the last 4 months, she's had no bleeding whatsoever and no pain. And so this is the dance I do when we've won and that we've managed to help. And I think actually patients like Bella are pretty common in general practice. I think GPs are managing adolescents with period pain every day, and it's probably something most of you feel pretty comfortable with. However, I guess we all know that managing painful periods and pelvic pain isn't always as easy as this. And so we come back to Bella again, but she's all grown up and she's 25 years old now. And you haven't seen her in a while, but she comes back in after an ED presentation for lower abdominal pain. It was pretty stressful for her because they were querying, serious things like appendicitis, and they were talking about ovarian cysts. But in the end, all of the investigations actually came back normal. After talking to Bella a little bit further, she tells you that 18 months ago, she stopped her pill because she's been hearing a lot of stuff on social media about how all hormones are evil and unnatural. But unfortunately, after she stopped her pill, after a few months, her period pain returned. After 6 months, particularly in the last 6 months, she's had an increasing number of days a month with pelvic pain. She reports problematic pain 10 days a month. But when you query it further, she's actually getting mild pain on most days. She's also had worsening pain with sex for the last 3 months and issues with variable bowel habits and bloating. So Bella is actually now fulfilling the criteria for chronic pelvic pain. We don't have great numbers on how prevalent this is, but our best estimate is that it affects up to 15 to 25% of women and 8% of men in Australia. Endometriosis is estimated to affect about 11% of Australians that were assigned female at birth. And so looking at these numbers, it makes you realise just how common chronic pelvic pain actually is. And so it's probably something most of you in the audience see a lot of. And like I said, I really do find that many of my cases are actually like Bella, and they really don't necessarily volunteer how often they're experiencing pelvic pain. The other thing about these estimates is they do suggest that probably about half of our patients with chronic pelvic pain have underlying endometriosis. This actually also means that half of them do not have endometriosis. And I think it's important to remember that obviously they're not making it up. And I don't think any of you out there think that, otherwise we're probably not going to be at our talk. But our previous dialogue has really focused on chronic pelvic pain and endometriosis. And this can be quite invalidating for those patients that don't end up with a diagnosis of endometriosis. My communication to patients now focuses on pelvic pain being a diagnosis in its own right, with or without endometriosis. And so obviously we're talking about what role do GPs have, and it's useful to think about what skills do we already have in this area. And so I've broken it up into 4 major themes. As we talked about, GPs are already pretty good at menstrual cycle management. We're also pretty good at chronic disease care coordination. We see a lot of chronic pain coming through our doors, and do a lot of education and management of this. And I think we do a pretty good job of listening and validating. I hope you guys all like my very cute puppy. It's not mine, but I thought it was a cute picture. Listening and validating is probably the first step of our chronic pelvic pain. Our first step, sorry, to chronic pelvic pain, particularly in our pelvic pain clinic. And I admit it can be a bit more time consuming than writing a referral for an ultrasound or a gynecologist. However, it can result in much healthier attitudes towards pain. I find that actually listening to these women's stories can be pretty humbling to learn just how tough women can be. Often these women are telling me how from, a young age of maybe 11 or 12, having awful, horrible period pain that leaves them lying on the floor crying or sometimes vomiting, or some of them even talk about passing out. And I think this is pretty heartbreaking to hear, particularly I'm a mother of 2 daughters, and I would never want this to happen to my children. Yet for some reason in our society, period pain is very normalized and often goes unvalidated and untreated. And as a result, a lot of our women can be often quite traumatized by this experience. And taking that time to listen and let them know their symptoms deserve treatment is really important. Now, I will admit, true validation of potentially 10+ years of pain and the trauma that comes from that isn't always a 15-minute job, and that can be hard in general practice. I'm very fortunate working in our pelvic pain clinic that we get all of our patients to fill in this form, and they get our nurse to do their initial intake appointment. And so by the time I see them, it's not too hard for me to convince them that I'm on their side. It can be a little bit more challenging in general practice, where often these patients don't interact with the system in an ideal way. And so what I try and focus on with the little time that I have when I'm in general practice is just spending an extra 5 minutes validating their pain and inviting them to come back for a longer consult, which is something GPs are very used to doing. And they won't always come back, but sometimes they'll just file that away, that their pain is important, and they'll come back when they're ready. And so for Bella, you listen and validate her pain, and you allow her to decide what are her priorities for management. And for Bella, she really would like to investigate her pain because she's still quite scared and worried something might be wrong after her ED presentation. She'd like to improve her pelvic pain. She'd like to improve her pain with sex, and she'd like to improve her bowel symptoms. So obviously, we've got multiple things that we're looking at doing for Bella, and having someone who's skilled in chronic disease management and care coordination is essential, and that's where GPs come in. And so for someone like Bella, we might be thinking about getting our really talented pelvic floor physios like Emma, who's going to present next, involved. We might be also talking to our dietitians to help manage her bowel symptoms. we might be talking to our psychologists to help manage some of that emotional response. And these patients are very eligible for a chronic disease management plan. Now, this comes from a great paper by Sue Evans and shows just how common comorbidities are with pelvic pain. And actually, this looks at comorbidities with dysmenorrhea, so not chronic pelvic pain. And they're already really, really common. And they're even more common in chronic pelvic pain. So, you know, even just with painful periods, you're getting at least 50%, nearly 50% of patients having bowel symptoms, 50% of patients having headaches, 74% of patients having fatigue, and over 50% of patients experiencing some kind of mood symptom. And obviously, we're going to have to consider in these patients the chronic pain management aspect. And actually, I think GPs, this is bread and butter for most GPs because chronic pain is a really common presentation that walks in the door. And I think all of us are pretty used to bringing some basic pain science concepts into this space, particularly for our chronic musculoskeletal pains, our chronic migraines, our fibromyalgia. You know, with our low back pain presentations, we're pretty confident talking to them about the fact that their severity of pain doesn't link well with the underlying pathology or imaging, or explaining to our chronic migraine patients that their pain is real, even though we don't expect any changes in our imaging. Now, pain science education is really important in pelvic pain, and it's what takes up a lot of our initial doctor's consult in our pelvic pain clinic. And I know that in Canberra, a lot of our pelvic floor physios do a great job in this space, and I know Emma's covering this more, so I won't dwell on it. This was a great paper that covered some of the big themes in doing pelvic pain specific pain science education, but I'm pretty sure that Emma is having a chat about it as well, so I'll skip over this for the time being. And I thought I'd briefly include this. This is what my diagrams end up looking like by the end of my first appointment in our pelvic pain clinic. It looks pretty messy, but I think it makes a really big difference to our patients being able to understand what's going on with their pelvic pain. Obviously, this is not what we expect GPs to do in a 15-minute consult, but I don't think education has to happen necessarily all at once. And I think definitely, so long as we're all speaking the same language, sometimes just having a couple of points from their GP in that first consult means that that's something that either us in the pelvic pain clinic or their pelvic floor physio or pain psychologist can then build on. And now I've mentioned trauma a few times already, and I won't attempt to explain trauma-informed care properly, except I put this slide in to make sure that I mentioned that trauma-informed care, I think, is something that's worthwhile for every clinician, regardless of which space you're working in. And I found this quote a really nice way of summarising it. And it says, trauma-informed services do no harm. They do not re-traumatise or blame victims for their efforts to manage their traumatic reactions, and they embrace a message of hope and optimism that recovery is possible. In trauma-informed services, trauma survivors are seen as unique individuals who have experienced extremely abnormal situations and have managed as best they could. And that quote comes from Dr. Kathy Kieselman, who is a doctor and also the president of Blue Knot Foundation, which does some great education in trauma-informed care. So coming back to Bella, you did give her a referral for a specialised ultrasound. And after talking through all of the options, she decides to have an implant on. You also arrange a GP management plan, and have given her referrals for a pelvic floor physio and a dietitian. So Bella returned 6 months later. She did have a negative ultrasound. She was initially a bit nervous about seeing a pelvic floor physio, but you talked her through about the fact that they do a lot of education and don't necessarily need to do any touching in the first instance. So she ends up seeing that pelvic floor physio, and she found that that really helped her to understand her pain and how to manage her pelvic floor. She did struggle with spotting in the first 3 months with the implant on, as a lot of our patients do. But she used the combined pill for that first 3 months, and it is now settled. Her pain is much better and has reduced to 2 or 3 days a month, and now the pain is much more manageable. She didn't actually end up seeing that dietitian because as her pelvic pain improved, she found that she was getting some benefit in her bowel symptoms. And she continues to see the pelvic floor physiotherapist to work on her pain with sex. And so this is our celebration again. Before we move on to maybe a slightly more trickier case. And this is Florence. And you're having a whole week of pelvic pain because she also comes in after an ED presentation for lower abdominal pain. She just had bloods and they were normal, but she was given opiates to manage her pain. And she's actually had 3 similar presentations already over the last 12 months. And in one of those presentations, she was diagnosed with an ovarian cyst. When she comes into you, her pain is actually much better than it was, but she's pretty worried because she doesn't feel like she was given a reason or a cause on what actually was happening with her pain. And so a little bit more about Florence. Her period started at 12, and they were always painful. She's never had any previous hormonal contraceptives. She did tell you that she went to her GP at 14, but at that stage she was told that she was too young to start anything and that she should just use Panadol and a heat pack. At the moment, she's missing about 3 days of uni a month. And she's got quite heavy periods. She's changing her pad or a tampon every 2 hours on the heaviest days, and often getting overflow and clots. You can see from her record that a Mirena was suggested to her 12 months ago by another GP. And this, looking at her records, looks like a bit of a pattern of not necessarily engaging with management plans and suggestions. And this is really common, obviously, in this patient population, who can often find even our consult rooms quite triggering, and will often agree to unsuitable management plans just to get out of the room, but then never actually follow up. And so already we're identifying that this is a patient that it's going to be really important that we give her as much education as possible to try and make them feel like they're back in control. Florence also tells you that she's planning children in maybe another 2 or 3 years. She also has a background of chronic migraines. She tells you that she's intolerant to gluten and that she has recurrent UTIs. And there's also a query of possible anxiety and depression. She had a mental health care plan done 6 months ago, but once again, there's no evidence that she actually went and saw that psychologist. In terms of her medications, she currently manages both her migraines and her period pain with Panadine. Her mother had a hysterectomy at 37, and Florence thinks that was because she also had painful periods. She lives with her long-term partner, and like many Canberrans is working in the public service. She's a non-smoker, and she does walk her dog most days. And she also does reformer Pilates once a week, which now that she thinks about it, her pain is often worse after this. And so because Florence is quite keen to do some more investigations, you do refer her for a specialist ultrasound. And the report comes back showing some site-specific tenderness suggestive of possible underlying endometriosis, but there are no other findings. And so this is our last poll. If Kunal, you don't mind putting up the third poll, that'd be great. And so this is asking you, what are your next steps for Florence? Now, hopefully we did try and set this up so that you can select more than one answer, which unfortunately is why I think the last answer asks, could we select more than one answer? But if you can't, feel free to select the bottom one. Okay, and I might end it there because we've got 80% of our participants who have answered. And we've once again got a mixed lot of answers. And I think that they are all definite considerations of what we might offer for Florence. And ultimately, I think the important part of this is actually letting Florence be in control. Definitely some patients, once they know that they have signs on an ultrasound of endometriosis, want nothing more than to be referred for surgery. But a lot of patients are very keen, mostly to manage their symptoms. And that definitely can happen both with hormonal management and non-hormonal medical management. I will say that whilst it might be beneficial for Florence's potential underlying endometriosis for her to be pregnant, because there is some evidence around regression of endometriosis during pregnancy. Obviously, we want Florence to start trying when she's ready to. And definitely, she's already talked about 2 or 3 years. And it's important not to, once again, to give her control over that. She can know that it might be beneficial, but I would avoid being that our only management suggestion. And I'd probably also make sure that whilst it is up to Florence if she wants to watch and wait, that she does understand that the longer we leave this for, the more pain sensitized her system becomes. And so that can be problematic, particularly if she's thinking about pregnancy in a couple of years and she's got worsening things like pain with sex. If we don't actually step in soon, it might be an increasing issue. So fertility is obviously a big consideration for someone like Florence. And I think it's important for us to think about what do we know about how endometriosis affects fertility? And so we know that in patients presenting with subfertility, the rates of endometriosis are higher than the general population. But the current research actually suggests that probably 50 to 70% of women with endometriosis actually fall pregnant without intervention. Though this might drop a little bit when we're talking about people with more severe end of the scale. We know in general there isn't a lot of benefit for earlier surgical intervention for fertility. And that comes back to that concept that that first surgery is the one that we get the most benefit from. And we generally see in the literature that's probably has its best effect in that first 6 months. And we know, obviously, if someone's trying to fall pregnant right now, that medical hormonal management is not something we want to use. And in terms of managing fertility in those women with endometriosis who are struggling, there is still a lot of controversy around whether we use assistive reproductive technologies versus surgery or some combination of both. And the literature is a bit mixed about this. And obviously, a couple of us were thinking about surgery for Florence. And we know, obviously, surgery continues to have a role in endometriosis in the context of both pain and fertility. It's not always the cure we hoped it was 30 years ago. And as we discussed before, not only is it not necessarily the cure, but probably actually about 20 to 40% of women will experience the same pain or worse after a laparoscopy. And just how effective it is on proving fertility outcomes is actually a bit controversial in the literature, with some studies quoting that you actually need to treat 12 women with laparoscopy and surgical management of endometriosis for one pregnancy. And so we come back to Florence. And after talking about all of your options, she's really keen to actually start trialing some anti-inflammatories to replace her Penadine. And after thinking about it, she's really not ready to fall pregnant right now, but she'd like to go with an option that's going to be most quickly reversible when she does decide that she wants to fall pregnant. And so she's actually chosen to have a Mirena inserted under sedation. She doesn't currently have private health insurance. And so she elects to have a public referral for the endometriosis clinic. But under your suggestion, she promises to sign up for top-level private health insurance. And she's quite bothered by her gut symptoms. And after you talk to her about the newer evidence surrounding gut-directed hypnotherapy, she's quite keen to try this, and she's going to sign up for the Nerva app. She's a little apprehensive about physiotherapy, even though you have reassured her that this doesn't necessarily involve an examination or anything invasive. But she does agree to take some of the information you have about online physiotherapy options. And she is happy to swap out her reformer Pilates session, which is probably dialing up her pelvic floor a bit, for a yoga session once a week. So hormonal IUDs and pelvic pain. So there's a lot to say in this space, and obviously we use them quite frequently in pelvic pain and endometriosis. But there's a lot of considerations here. And obviously the first that we're often thinking about is, do we use a Mirena versus a Kylena? Obviously the Mirena has been around for a very long time and does have some evidence around post-surgical management of endometriosis recurrence, which the Kylena doesn't have. However, there are some considerations around the Kylena being a smaller IUD, and probably the evolving evidence says that there's probably about 15% of women that do notice a difference in having that smaller IUD. We know that both seem pretty effective for decreasing period flow and menstrual cycle suppression. And as we talked about, the Mirena is good for preventing recurrence of pain in endometriosis. And they both have a really rapid return to fertility, given that most people continue to ovulate. Now, you've probably all heard, particularly towards the start of last year, there was a lot of media about hormonal IUDs and pain during insertion. And I think this is a really relevant concern, particularly in this patient group. The data often talks about these patients at being higher risk for having painful IUD insertions. What I will say from my experience is that the pain during insertion in these patients, they often tell me that they have had worse pain with their periods, which I think is just awful. However, and so they often tolerate the actual insertion really well. However, they do tend to get more pain post-insertion. And look, that's probably the fact that both their pelvic floor muscles and their nervous system, which are already primed and quite sensitive, really dial up after the insertion. And it's super important to warn them of this because a lot of them get told that they should only experience pain in the first 24 to 48 hours. And unfortunately, that means that when they're still experiencing pain a week later, they also have all of that fight and flight, stress, anxiety response going on because they're worried that something might have gone wrong. So it's really important in these patients, if you do refer them for an IUD, to have a bit of a plan, provide that education that having some pain can be normal, but so long as it's slowly settling over time, it isn't anything to worry about. Providing them with anti-inflammatories, pelvic floor stretches or relaxation sometimes can be helpful, and making sure that they've accommodated for it in their life, you know, that they have medical certificates, that they haven't, you know, arranged to do a big thing at work in the following week. And a trauma-informed approach in this space is really, really important. And so we come back to Florence, and you're seeing her 12 months later. And she had a marina inserted under sedation, and her pain did flare quite a lot after the insertion. But she said she managed it okay because she knew that she was expecting it, and she'd already had some things in some plans in place, and had a really light week at work planned. She's now had no bleeding for the last 6 months, and her pain is better than it was, but it's still there. She's no longer requiring opiates. She actually did do one of those short online physiotherapy courses, and she had to admit that she did find it quite helpful. So she's now ready to think about seeing a local physiotherapist to try and build on some of those concepts. Now, this brings me to the end of my talk, and this last slide is just quickly about self-care. I know a lot of the audience will probably be women, and given the prevalence of pelvic pain in the population, there is a good chance that there's a fair amount of lived experience. So I think it's important, regardless of whether you have lived experience or even if you're just working in this space, which can be tough, to be kind to yourself. And I hope this is giving you a couple of more tools to help you work in this space. Just a quick plug, we've recently re-established the ACT Pelvic Pain Network, and we'd love to see more GPs or other of our pelvic pain colleagues come join. You can scan this QR code or send us an email, and we can put you on the list. I'll leave this code for another 10 seconds, just in case anyone else is trying to scan it. And the last thing I'm going to mention is, as Michaela pointed out, I currently am the lead for our pelvic pain clinic here at Sexual Health and Family Planning ACT. And so for people who are wanting to refer into this service, it is a subspecialised service supporting patients and their GPs in the management of pelvic pain, and that includes painful periods, chronic pelvic pain, pain with sex, and other related conditions. Currently, we're a team of doctors, and we also have a fabulous pelvic pain nurse. And our first intake appointment with our nurse is free and can be booked via Hot Docs. We love having referrals from GPs or pelvic floor physios, but patients can also self-refer. Thanks. And I'll leave you guys to Emma.
Thank you, Tara, for such an excellent presentation. I'm now going to introduce our second speaker of the night. So our second speaker tonight is Emma Bowen. Emma is a director and founder of NOCA, who has completed an undergraduate degree in physiotherapy and a master's degree in continence and women's health. Emma is a titled physiotherapist, and the Australian Physiotherapy Association defines a titled physio as a highly qualified physiotherapist with expert knowledge and skills. Emma is passionate about pelvic health and aims to always provide quality care and education to women, men, and children who are experiencing problems with bladder or bowel function and pelvic pain. Emma has a particular interest and experience in treating patients with pelvic pain and sexual dysfunction. She uses an integrated approach to help patients achieve their goals and improve their quality of life. Please join me in welcoming Emma.
Thanks, Michaela. Oh, we might just, sorry, we just got to the other microphone off. Better? Yeah, I think so. I just share my screen. Can everyone see that screen now? You got that, Tara? Yeah. Cool. Okay, well, thank you for having me. I'm super excited to talk to you about pelvic health physiotherapy tonight. So as you heard, I am a pelvic health physio and I work in our clinic at NOCA, which is based in Deakin. And so just a little rundown of what we're going to talk about today. So just going to take you through what a pelvic health physio does and who we are, and then we'll review the pelvic pain conditions that we commonly treat, take you through some of the assessments that we use, common treatment techniques, and then review, which is all important, the collaboration in our MDT teams, and then just share some of the resources that we in clinic find useful as practitioners, but also find really useful to share with our patients too. So a pelvic health physio is basically a physio who has had specialised training to become an expert in this space of women's, men's pelvic health. And we have extra skills in the treatment of male and female pelvic floor dysfunction. And that includes urinary bowel dysfunction, pelvic organ prolapse, sexual dysfunction, and pelvic pain. There's many terms that are used to describe pelvic health physios, which we're trying to sort of move towards that as a term because we feel it's more inclusive. But commonly we might be referred to as women's health physios, pelvic floor physios, continence physios. But yeah, we prefer the term pelvic health physio. In Australia at the moment, there are, sorry, my mouse is just, there we go. 2 pathways to becoming a qualified or titled women's health physiotherapist in Australia at the moment. The first is through tertiary education. So Curtin University in Perth and Melbourne University both offer a postgraduate certificate and a master's at Curtin University in continence and women's health physiotherapists. And so the second pathway available to us at the moment is through our APA, which is the Australian Physiotherapy Association. This pathway is only in development currently at the moment. So people engaged in that have not yet completed that pathway. So I think it's just worth noting that some women's health physios may not necessarily have had postgraduate studies, but it's really worth checking out people's bios online to see their training and their background and experience when referring to pelvic health physios. Okay, so the conditions that we treat. So we see in the population, we treat patients who have urinary incontinence, fecal incontinence, pelvic organ prolapse, pre and postnatal conditions, bowel dysfunction. And then under the banner of pelvic pain, we see patients who have endometriosis, bladder pain syndrome, interstitial cystitis, vulvodynia, and dyspareunia, painful sex, painful intercourse. For today's talk, we'll be really focused obviously on our pelvic pain patients. So Tara has already defined pelvic pain, but persistent pelvic pain is pain that is felt anywhere inside or outside the pelvis and in the lower abdomen that is present for most days for more than 6 months. So just reflecting a little bit, I guess, on occurrence and then also the cost of pelvic pain. So persistent pelvic pain affects 1 in 4 of those women or assigned female at birth in Australia. And those living with pelvic pain experience some other difficulties. Comorbidities are really, really common. Jean Hales last year conducted a survey that showed that 4 out of 5 of those with pelvic pain reported that they'd missed work, school or study or exercise due to their pelvic pain. A half of those surveyed reported significant impact on their mental and emotional well-being. 1 in 3 reported a negative impact on their relationship with their partner, and 1 in 10 reported that they had some negative impact on relationships with family and friends. So it's got a significant cost. And then if you add to that the financial cost for these patients in terms of accessing treatment, medication, and time lost from work, it is a really significant thing for these patients. Comorbidities, as Tara has already mentioned, are very common in this group. So IBS, bladder symptoms, TMJ, jaw pain, headache, migraine, anxiety, depression, musculoskeletal pain, and fatigue we see commonly in these patients as well. Okay, so this is how a model for how we look at pelvic pain, and it can be a bit of a complex puzzle. We generally divide, pardon me, the drivers for pelvic pain into 3 categories, which you can see here. So organs, muscle, and central nervous system. And we're going to go on to explore each one of these now. But it's really worth keeping in mind 2 things, is that it's really common for patients to have more than one driver for their pain, or an overlap of all 3, and that the psychosocial factors can always influence pain. So it's there as our 4th little piece of the puzzle to always keep in mind. So first thing we're going to look at is our organ-based drivers for pain. When we consider gynecological causes, Tara's already mentioned that painful periods are a common cause, endometriosis, ovarian pain, pelvic congestion syndrome. Then when we come to bladder, things such as bladder pain syndrome, interstitial cystitis, recurrent urinary tract infections. In the bowel, things such as irritable bowel syndrome and inflammatory bowel disease. And then in vulvovaginal space, things such as vulvodynia and dyspareunia are all common causes of pelvic pain in the patients that we see. So the second component, the piece in our puzzle that we consider, and I guess this is sort of our money in terms of what we specialise in, is that pain from pelvic muscles themselves is really common in pelvic pain patients. Tension in the internal and external muscles of the pelvis and the lower abdominal wall are often as a result from inflammation in those organs that we've just mentioned, or pathology in those organs. And quite commonly the muscles respond by tensioning. The wind up in these muscles can then generate pain in the muscles themselves, and we'll go on to have a conversation about how they can have a conversation then with the organs. And then, of course, the nervous system. So if we consider the impact that pelvic pain can have on the nervous system and the changes that can occur, the first thing we think about is peripheral sensitization in the peripheral nerves. And this is that characterized by the increased response in the peripheral nerves. They have a lowered threshold then to the nociceptive neurons to stimulation. In an acute setting, this peripheral sensitization is very helpful because it will protect the affected area, and it assists with healing because basically it's stopping people from using that part of their body or protecting that part of their body. But in pelvic pain, there's often prolonged nociception, and that can be from the organ itself, but can also be due to continued inflammation in the organs, continued inflammation of the nerves, a process we call neurogenic inflammation, and that can then result in continued activation of nociceptors. And then also central mechanisms that maintain this peripheral nociceptive mechanism may be impairing the actual inhibition of pain. And so what happens is we're ending up with a prolonged peripheral sensitization in these patients. And I think it's really worth noting that Tara was referring to the fact that, pain science is pretty common to all of us in our everyday practice, and we kind of lean into that mantra of saying to patients that, tissues heal and things should be resolved in, 3 months. But in the case of pelvic pain, quite often the patient is still experiencing that noxious stimulus. And so we have to keep that in mind. And that's the factor that probably differentiates pelvic pain from other chronic pain conditions. And that addressing of that noxious input is really critical for these patients to make long-term changes to their nervous system. So if we go back to this prolonged peripheral sensitization, we can then explore central sensitization, which is that increased response then in the central nervous system. And the chronic hyperexcitability of those peripheral afferents is then leading to those long-term signaling changes in the central nervous system. But there's more. If we then go on to explore the complex changes that can then occur in terms of the conversations that the organs, the muscles, the central nervous system have, the concept of cross-sensitization. So firstly, if we look at viscero-viscero convergence, if you look at the picture on the right-hand side, it shows uterus, bladder, bowel, and you can see that all of these visceral organs, they share common nerve pathways to the dorsal root ganglion and the spinal cord. They have shared dermatomes and ascending spinothalamic tracts. And so what this means is the communication between these organs is quite easy. And so you can see them start to talk to one another and upregulate one another. And so what we refer to there is cross-sensitization. The second thing that can happen is viscerosomatic hyperalgesia, and this is where those noxious afferents from the viscera, again from the organs, are converging with the somatic afferents, so things to do with skin, muscles and joints, and they result in the pain symptoms in these tissues around the organ. Even more complex is then that the actual pelvic floor itself, so we take one of those tissues in the somatic system, and we know that it can actually then trigger a response in the organ. So it is a reverse and possible for that increased tone perhaps in your pelvic floor muscles to cause those visceral symptoms. And we think that's due to the fact that the mechanical compression of the organs by shortened muscles, tight muscles, or again by this viscerosomatic convergence that we have. And the diagram on the left is great at explaining that. So you've got organ talking to organ, pelvic floor, so organ talking to pelvic floor talking to organ, both of those things talking to the central nervous system, resulting then in this central sensitization with the symptoms of allodynia, hyperalgesia, and expansion of the receptive fields. And we'll go on to explore a little bit later about allodynia and hyperalgesia further on in the talk. So that was background on changes that occur with our pelvic pain patients. And now we're going to have a little look at physiotherapy assessment of pelvic pain. So Tara covered this beautifully. I think we're in a really lucky, fortunate position as pelvic health physios, particularly in private practice, where we get to have an hour initial with our patients as well. So we're given that gift of time, which then really allows us to validate our patients' stories, listen to them, and give them a safe space to tell their story. I think understanding a patient's views is just critical for goal setting, treatment planning, and we use questions that are similar things to what do you believe is causing your pain? What do you think needs to happen to change your pain? And we really try to focus it on the individual so that we can help focus treatment based on their actual needs, goals and wants. And I think, as Tara said, sometimes these patients they do feel that they have been dismissed or not validated or had some medical trauma. So the time spent in this initial is critical to form that rapport and to help them feel safe. In our subjective assessment, in terms of the baseline things that we try to capture, we're looking for data on comorbidities, their pain generators, aggravating and easing factors for their pain, their bladder, bowel and sexual function, information about their menstrual cycle, information about their lifestyle, including what type of exercise they do or don't do, their sleep quality, their level of stress, and also if they have any toolkit strategies, which is things that they already have in place to help them manage their pain. And at the conclusion of our subjective examination, we are always asking patients what their goals are. We tend to rate bother in our subjective examination, so we'll be getting them to rate their bother with their bladder, their bother with their sexual symptoms, and that can just help at the end of the session, I guess, prioritise where they might want to start and focus initially. But I think it is really important that we never assume what a patient's priority should or will be, and we need to ask the patients that. This is definitely a space that I think we're all really familiar with, and in pelvic pain, it is essential that we are all practicing in this biological, psychological, social model, so the biopsychosocial model that takes into account the fact that biology is part of the story for these patients, that we've already covered all of those reasons, but that we must acknowledge that their psychological state, things like stress, fatigue, mood, sleep, all will impact on how somebody perceives pain. And then the significant impact as well that social things might have, relationships with family, their work experience, they can impact on how they perceive their pain, but also then that their pain can impact on social life and factors too. So they can be withdrawing from those things due to pain. So it is a complex story for most of these patients. So while we're gathering our subjective, we are trying to pick out all of those psychosocial factors that might be part of each patient's unique story. However, we do sometimes find that objective measures and screening tools can be really, really helpful with these patients to help us identify anything we've missed, but also to help them perhaps, again, identify things that they hadn't perhaps recognised or thought of as something that might contribute to their pain. They're also really good as a point in time measurement. So we might do these, we might send the patient home with these, conduct them within the first few appointments, and then revisit them in 4 or 5 appointments to make sure that we're actually seeing change, to meaningful change, and change that is objective too. So it can help the patient see that, but also make sure that we're on track with achieving our treatment goals too. So I've just listed the common ones that we use in clinic. So the PPIQ is the Pelvic Pain Impact Questionnaire. And it's really about, so it's patient generated, it's really easy to use, it's got strong psychometric properties, and it's picking out how much this pelvic pain condition is impacting on their quality of life. It is readily available online. We do tend to use the central sensitization inventory, and this is a self-reported outcome measure designed to identify those patients who have symptoms that may be related to central sensitization or central sensitivity syndromes. So some of those things such as fibromyalgia, neck pain, TMJ disorders, headache, migraine. So that is a useful screening tool. The Tampa scale is brilliant. So it's a Tampa scale for kinesiophobia, which is basically a fear of movement. So that gives us a really good read on how people might approach exercise or their tolerance to movement. So it's a good baseline measure to have. The DAS-21, I'm pretty sure everyone in the audience will be really familiar with that it's obviously a measure of depression, anxiety, and stress. And we use that to screen and refer back to GPs if need be for follow-up from that. A new questionnaire that we've started using in clinic is the 3PSQ, which was developed by Jane Chalmers, and it's a pelvic pain psychological screening questionnaire. It's got 15 items, and it's screening for the presence of 13 psychological factors in individuals with pelvic pain. So it's quite useful, and I encourage you to have a look at it. I've put the QR code there for you all to scan because it is in its draft form. As far as I'm aware, Jane is really happy for people to be using it in clinic and then feeding back to her how they're finding it, whether it's useful. So definitely check it out and see if you might be able to include that in your practice. Okay, so physical examination that we conduct. So broken it down into 3 components just for ease. And this is generally, I think, probably how most pelvic floor physios would work when we're assessing our patients. The first thing we look at is the regional system. So we're just looking globally. We're looking outside of the pelvis. We're looking at any dysfunctional movement patterns that patients may have adopted due to pain. We're looking at any tension patterns, restrictions of movements, commonly in things such as TMJ, cervical spine, headaches. So we might be assessing them there. And we'll definitely be looking at their breathing patterns, the muscles of respiration. There is definitely a relationship that exists between the diaphragm and the pelvic floor. Commonly, pelvic pain patients will adopt an upper chest, often scaling breathing pattern. They're triggered into that sympathetic nervous system. They commonly find it really hard to breathe into their diaphragm and to belly breathe. And so we're just screening for that and seeing what their normal natural process is and I guess really how much time they're spending in that upper respiratory system as a cue for how much time they're being triggered into that sympathetic fight or flight system. Then, so I've put vaginal examination second, but I think it's really worth pointing out, as Tara mentioned, quite often we are not doing a vaginal, I would say the majority of the time we are not doing a vaginal examination on our first consultation. And the reason being two things, time, number one, but also just rapport with patients and safety. I think you need to explain to a patient what that is and why you're doing it, and then let them process that. And I will often send them home with that explanation and let them decide, but also present them with other options that we can gather information with that's not a vaginal exam. I think Tara's points on patients being petrified of vaginal examination, they come in and they're not focused because they're just worried about getting that bit over with. So I flagged that quite early on, that we're really about gathering information in that first consultation and making a plan, and that it's only a part of what pelvic floor physios do. In saying that, if patient has consented and understands why we're doing it and feels it's valid and meaningful for them, when we do a vaginal examination, there are two components really that we're looking at. The first part is a visual examination. So we'll be looking at the skin and mucosal health. We're looking for any signs of inflammation, infection, hormonal changes in the skin. And then quite often we'll be looking at any nerve changes in the actual skin itself, and we will perform a Q-tip cotton test. I'm not sure if everyone's familiar with that. It's a cotton tip around the bulbar vestibule, and you're basically looking for any areas of pain, any altered sensation. And what we're using that to screen for is those terms we were referring to before, which is that hyperalgesia, which is increased sensitivity in that area, or allodynia, where they're actually saying, no, that feels really painful, scratchy, sharp, and it's the cotton tip. And you'll be showing them on their thigh what it might feel like, and then repeating that perhaps in the bulbar vestibule and comparing the two so that they get a read that it actually does feel different. And it's a sign of that peripheral nerve sensitization that we were talking about previously. So once we've done the visual, we will then move on to our pelvic floor muscle assessment with vaginal examination. And we assess superficial pelvic floor and levator ani. And we're assessing for tone and tenderness, and the next slide will go into a little bit more detail on that. And then finally, I think, as I said, it's worth noting that we do have other options. And quite often we will go to real-time transabdominal ultrasound. It gives us the ability to assess breathing patterns, look at movement in pelvic floor. We can't assess tone with real-time ultrasound, but we can certainly get a read on how connected a patient is to being able to move their pelvic floor and what their breath does to their pelvic floor. We can record bladder volumes. We can see if they're emptying their bladder well. We can do a pre and post voiding volume, all using real-time ultrasound. And it can be a really nice visual biofeedback for patients. And it's a soft treatment technique, and it's often more tolerated than vaginal examination. And a little bit more detail on vaginal exam. So pelvic floor assessment with vaginal exam, we are looking at tone and tenderness and movement. So superficial pelvic floor, bulbocavernosus, ischiocavernosus, and transverse perineum, and then assessing levator ani, iliococcygeus, pubococcygeus, and puborectalis. So this is done internally, vaginal examination through palpation. Terminology is important to pelvic floor physios, and we talk lots about tone. And it's defined by resting tension. And what we're looking to do is assess resistance to passive movement. And we do that by applying stretch or passive sort of resistance to those muscles and basically feeling tone and how tight those muscles are. We then rate that tone as normal, decreased tone, or increased tone. And that's just current terminology you probably have heard lots of different things used to describe tight pelvic floors, upregulated pelvic floors, wound up pelvic floors, hypertonic pelvic floors. All of those things have been used to describe tone. And so currently we're trying to normalize, standardize how we describe it. So we're describing tone in pelvic floor as normal, decreased, or increased. Decreased tone in pelvic floor is probably perhaps a group of patients that you might be more familiar with, those patients who potentially are incontinent, have pelvic organ prolapse. They will be the patients that generally have lower tone. We still see those patients, but when it comes to pelvic pain patients, it's much more common for these patients to have greater than normal tone in their pelvic floor. and a small elevator hiatus. We are also assessing for tenderness. So we're just asking the patient, do they have any sensation of discomfort or pain? And we're trying to note the location of that pain and the severity of that pain. And we will often use a numerical rating scale to document that. So if we do find, and I've put there impacts of pelvic floor muscle dysfunction, what I'm really referring to here is the impacts of greater than normal tone in the pelvic floor. Pelvic pain is probably the number one thing that we've already described how that occurs. And then some of the bladder urinary symptoms can include bladder pain, pain with urination, frequent urination, difficulty starting a wee, a feeling of incomplete or actual post-void residual. And then the bowel symptoms can include very similar things: difficulty initiating, incomplete emptying, pain, and pain with passing a bowel movement or pain with gas. Sexual symptoms under that heading of dyspareunia, so pain with penetration and inability to achieve orgasm. In those assigned male at birth, sometimes erectile dysfunction and ejaculation pain can be signs of greater than normal tone, increased tone in pelvic floor. And then increased tone can also, as I mentioned, narrow the hiatus, so that can make examinations, ultrasounds, smears difficult for these patients and painful. And they often report difficulty or inability to use tampons or menstrual cups. And just to give you some insight, I guess, into how we explain this to patients is that there are times when we need length in our pelvic floor and we need range of movement and that pelvic floor to relax. And that's certainly when we do a wee, when we do a poo. And as a whole, basically, when we get anything in or out of the vagina, we need length in the pelvic floor. And so they tend to comprehend that quite well. They might be having difficulty with all of those things or some of. Okay, so how are we involved in treatment of pelvic pain? Again, I've just broken it down into some different components just for ease of talking through the different parts that we do treat. I've put pelvic floor first because I think that's probably, as I said, what we're best known for, and how we actually then address this increased tone in the pelvic floor. We talk lots about pelvic floor muscle down training, and that's a technique which just involves a combination of different relaxation techniques. We talk about patients checking in with their pelvic floor, so that they might be doing a micro check during the day where they stop and they actually get a read on what's happening. Are they holding tension in their pelvic floor? Can they widen their sit bones? Can they sit with their feet on the ground? Can they actually melt their pelvic floor? Do they feel that they were already slightly contracted? Can they do a slight lift to let go and reset that pelvic floor into a state of relaxation? So just getting more familiar and having that connection with their pelvic floor is really helpful. And we use cues like melting and pancake batter to the edge of the pan for them to help facilitate that letting go of their pelvic floor. Diaphragmatic breathing, as I've already mentioned, that relationship between the diaphragm and the pelvic floor. So it's something that I think patients always think they've been told to do, but they don't often understand why breathing works. And it's definitely because, as I said, that when the diaphragm contracts as they belly breathe, the pelvic floor relaxes. So they've got that reciprocal relationship. So if they can invest in doing some really good belly breathing, they're already doing some pelvic floor relaxation. So it seems really simple, but it's really, really effective for these patients. And it's a good nervous system reset too. So we try and factor that in as well. Breathe or move and stretch, I think, is, again, probably fairly commonly known and used. That little QR code there is for the Easy to Relax Your Pelvic stretches from the Pelvic Pain Foundation of Australia. They've just updated it. It's a great sheet. We have them laminated in clinic and we just give them to patients to stick up and try to pick one or two to do regularly. So some more of the manual therapy techniques that we use. This little wand here on the right-hand side is the pelvic wand. And that's a tool which patients can be taught how to use independently at home to, I'm not going to say release pelvic floor, but certainly to palpate pelvic floor and provide some biofeedback. This little green one vibrates, so it's really great for that patients being able to feel their pelvic floor and then facilitate that relaxation. It's certainly helpful, I think, for reducing tone, and it's very empowering for patients to feel like they have something in their toolkit that they can do that doesn't rely on a pelvic floor physio doing an internal release of their pelvic floor or examination of their pelvic floor. So we tend to use those a lot in clinic. Soft tissue massage and stretching. The other diagram shows Franklin peanuts, which there's a whole series of soft air-filled balls that we tend to use to show patients how to massage, but again, how to stretch and facilitate a greater stretch using those. They're fabulous. There's lots of YouTube videos on how to relax the pelvis using those. And we also we use those in our pelvic unwind class as well. So they're handy little tools, and most of our patients will buy some and use those either at work. They might be sitting on those balls at work just to facilitate that relaxation, have a set at home to stretch with. They're a great little product. And then sometimes we do manual therapy in the pelvic floor via vaginal examination. And again, I think to reiterate, what we're aiming for here is more desensitization of peripheral nerves via palpation. The patients get immense feedback from palpation and connection with the therapist. And certainly, I think my goal with patients here is much more about neuromuscular control and learning to relax those muscles. I think we've moved on from that image of stretching tight muscles. It's much more around that neuromuscular control that we're influencing there with patients. So it can be very, very useful. So I'm briefly talking about this because Tara and I have agreed that this is probably a whole other in-service on its own about sexual dysfunction. But it's really worth noting that this is often high priority for patients because of the impact on relationships, and certainly in young women as well, in their sexual self and their sexual identity. It comes high in the score of bother often. And so I think this diagram is beautiful. It's just from a website, Hope and Her, but it describes very articulately what can happen with pelvic pain when it comes to pain with sex. That these patients will start anticipating that sex will be painful. Then they tense their body, which includes the pelvic floor. They possibly then go on to have sex, which is painful. That then reinforces the message and fires up their limbic system and sympathetic nervous response, which then leads to bracing and tension in the body. And so therefore then it then can lead to avoidance and impact on desire and intimacy and libido. But interestingly, in some patients, it actually leads to pushing through pain. And then that cycle of pain is self-perpetuating. And so it's a very difficult cycle to break. So our involvement in treating sexual dysfunction is definitely in the education and counselling space. And so we encourage patients to break from that pain-provoking activity, which is often penetration, and explore other means of intimacy and connection with their partner. We do lots of education with couples. So patients will ask, or we will ask patients if their partners would like to come along so that we can educate them on that previous diagram, give them some pain science education as well, so partners can be supportive of the journey. We often use graded exposure. So you might be familiar with, again, it's a common thing that pelvic floor physios are known for, which is dilators, where you're using graduated size of dilation in order for the patient to feel that they can do that safely without pain. But we also use intimacy graded exposure if that pain cycle has been happening for a long time and the patient is very fearful and has distanced themselves from everything related to intimacy, because that's a natural response when something is hurting. A process called sensate training, where it's a graded exposure to touch, can be really great for patients to slowly reintroduce prior to even attempting dilation or penetration again. So that's something that commonly we'll refer to as well. And then if we get to the point where they feel that they're safe and they're ready and they're wanting to try penetration again, we have a term that we say the 3 Ps are really important in returning to sexual intercourse. And we talk to patients about preparation, position, and penetration. So the preparation comes in the form of having a discussion about arousal and how that might have been impacted by pain, and are we addressing that? Things like lubrication being essential, and the position in which they're having sex, advising on which positions may be more comfortable, but more so being responsive to pain. And if they're in pain, that they should stop and change and try a different position. And also penetration depth can be altered in order to reduce pain. And those cute little products on the bottom, those O-nuts are designed to be worn on the penis, and you can stack them up. You can use all 4. You can use 1, 2, but couples find them really good because they can be responsive. But the idea is they're threaded onto the penis and they reduce the depth of penetration for the female partner, but male partners so far report that they're really comfortable and haven't impacted at all on sexual function. So just those practical elements around things they might be able to try to make sure that sex remains pain-free. General treatment principles. So bladder and bowel, bread and butter things in terms of reviewing bladder with bladder diary, looking at fluid intake, time of fluid intake, their voiding intervals. We look to optimize voiding. We teach voiding dynamics, which includes timed relaxation of pelvic floor, just trying to get that bladder functioning well. Very similar with bowel, optimizing diet, involvement of dietitian, referring to dietitian if we need, liaising with GPs, optimizing their stool type, and again, reviewing defecation dynamics. So looking at what's going on with their pelvic floor when they are defecating, retraining that, practicing that. We can use real time, or we can use transperineal ultrasound to do that. We've got lots of brace and bulge techniques that we teach patients to defecate well without pain and to optimize the chance of emptying completely. Musculoskeletal, again, very common for us to be treating, as I've mentioned, thoracic spine, TMJ, jaw, all of those muscles that are commonly involved in this tension pattern that these patients present with. Neurodynamics, we might be using neural sliders, flosses and glides to reduce nerve pain for these patients. And then general exercise prescription. And Tara mentioned this in her talk too, that some exercises are more likely than others to wind the pelvic floor up or increase tone in the pelvic floor. I think you have to pick the patient as well and really ask them what they love. And we definitely try to work with them to find a way that they can still perform the exercises they love. For example, they might love F45, and we're not going to say to them, you have to stop that altogether. But I think we can reduce the amount of intensity or modify some of the exercises, or perhaps add in a really good stretching regime post that so that they can continue to do those things they love. And in those patients who have a really low tolerance to exercise, we use a graded and paced approach. So they might be that old analogy of, building on a short walk around the block. And then if they feel good, they can double that, and just trying to communicate to them that they need to pace, and that's the way to avoid that boom bust cycle where they feel great, they go out and do a really intense exercise, and then they suffer and they have a pain flare and have to recover from that for days, weeks to come. And exercise physiologists, of course, are commonly involved. We are running short on time, but I am just briefly, I think this is really critical, this part that Tara mentioned before, which is about how we treat the nervous system. And I think we are really well placed in the space to be providing this education for patients because we have time. So Amelia Martin from the University of South Australia has just published this study, and it is titled, "I Wish I Knew Then What I Know Now," and it's pain science education concepts that are important for female persistent pelvic pain. And read the paper, it's excellent. To summarise that the 4 key components that of all the patients she surveyed, she came up with these 4 key themes that really impacted on recovery. The first was being that a sensitised nervous system leads to overprotective pain, which I think we've covered. That validates for the patient that the pain that they're experiencing is real. The second theme was that pain doesn't mean that my pelvis is damaged, although sometimes it does. Again, we've already mentioned that. But it's that reassurance that the condition isn't getting worse necessarily just because they have pain, or that pain doesn't correlate with tissue damage. That whole concept of something can hurt you but doesn't necessarily harm your tissues. And we use language in clinic, like things like you might be sore but safe, and things can hurt you but they're not necessarily harming you. So I think that's a key message for patients. Then third component was how I think, feel and see make my pain worse, can make my pain, make it worse. I think that brings in the psychosocial elements that we've already been talking about, and validating that all of those things, worry, stress, relationships, family, they all can impact as well. So it's really worth validating that for patients too. And theme 4, that I can change my pain slowly, and that empowers patients. And I will go on to talk about that in our next slide. Okay, so further things that we use, we'll cover education. Other stresses, I think it's really important to recognise, as we've said, that a sensitised nervous system is amplified when the patient is stressed, anxious and fearful. And we help patients try to identify those stresses and fears, refer on to psychologists and counsellors to try and get some strategies to reduce stresses. We have this nice little analogy in clinic where we say, you know, it's important to identify, you might be juggling balls, but try to identify what those glass balls are that are really critical, and are there things that are rubber balls that we can let bounce for a little while and just focus on these key glass balls, keeping them in the air at the moment to try and alleviate and allow capacity for change, which I think is really important for these patients. Sleep is critical. I think restoration of nervous system balance will reduce sensitivity. So, and GPs are great at this. We liaise commonly with GPs about patients don't even often acknowledge or realise that sleep can impact so much on their nervous system and their pain. So it's really important that they're sleeping well. Pacing, as we've already mentioned. So build on your activity, but keep that pain radar low, 4 out of 10, so that you're not getting into that space where you are going to do bust cycle, or your brain's telling you, no, this is dangerous, and you are harming your tissues. So we use that analogy. Graded motor imagery, things like visualizing movements, observing other people do movements and monitoring their response is very, very helpful for pain, particularly persistent pain that's been there for a long time. So they're rehearsing those motor patterns by imagining them. And it's a technique used in sport as well. It's very, very effective. And quickly to cover, David Butler and Lauren Mosley's concept of the protectometer, which is basically the diagram there that describes safety in me and danger in me, and that over time patients will have a series of things in their, I guess, that they have that have influenced their beliefs. And so things that they hear, see, smell, taste and touch, things they do, things they say, things they believe, places I go, people in my life and things happening in my body all shape these dangers in me or safety in me. And so we spend time with patients perhaps looking at some of those triggers that might have been a danger in me, but then we try to reconnect with safety in me. Things like your breath, what can you feel, that thoughts are not facts. We really encourage patients to stop and notice pleasant things and to relax tension. And that experience of joy and connection will definitely start to tip the scales in favour of safety over danger. Again, that's a concept. I think the protectometer, the NOI group there's an abundance of resources and explain pain. And there's an app as well for the protectometer that are brilliant. So in summary, I think the principle that we've got 2 main principles, I think, that we try to communicate to patients and for outcomes, and that our treatment and care should always be patient-centred, based on patient goals, not our perception of what they should be. We try to set small, achievable goals for success for patients and for them to regain control. We don't want patients seeing us forever. We want them to be able to self-manage, reach out when they need, but it's about giving them the tools that they need and also improving their quality of life. And the second thing we try to communicate is that it is these 10 percenters. There's lots of little things. The analogy of a trampoline, that all of the springs matter. If you've got 3 or 4 springs out of action, your trampoline doesn't function. But they are small things and it results in meaningful change, but you have to be persistent. If you focus all your energy on 1 or 2 springs in a trampoline, that's going to seem useless. And so it's just that commitment to time as well. And I think, again, I often say to patients, if you were to dump 3,000 litres of water on a rock in a day, you're not going to see any change in the rock. But if you drip a tap onto a rock over 2 years, that will actually indent a rock, which seemingly had no capacity for change. So it's commitment to long-term small change and persistence for these patients. But you need them to buy into that. Otherwise, you see them twice and they disappear because they haven't found effect from what you've been doing. So quickly to touch on flare-up toolkit, we look at what they can do in a flare-up, reassuring that the flare-ups happen, but there are things you can do to take back control and feel in power. So we look at stretches, movement, heat packs, TENS machines, finding positions and comfort of ease for patients so that they feel that they have the ability to reduce their pain, pain medication, and then relative rest. So that's validating that sometimes rest is good. They don't need to be completely sedentary, but listening to their body is important as well in that time of pain flare. And then healthy bladder and bowel. It's pretty commonsensical, really. This is just a summary slide of all of our treatment strategies that we've covered. And then last but definitely not least is that this is just critical for our patients, is that this collaborative approach, I think, is the key to success. We have to all work as a team to support these patients. And I really find once they find their village of practitioners that they trust, they are so empowered to recover and to have a better quality of life. And so you can see there's a vast array. And this isn't in its entirety. I've left osteopath off, mostly because I couldn't fit another circle in. There are other people on here who can fit into the team beautifully. This is that list of resources that I mentioned. So good quality, reputable information, which I think is critical as well. Sometimes patients are desperately trying to apply information and sometimes not useful information or perhaps biased in a negative slant. So we tend to use the Pelvic Pain Foundation of Australia. The Pelvic Pain Network of the UK has just, well, the last 6 months, opened up a whole lot of learning modules and resources and printouts. It's actually really great. Jean Hale's WIRIA, which is the Women's Health Research Institute of Australia, Endometriosis Australia, EndoActive, Endozone and Quendo are all fantastic resources online. And that is my references, and thank you for your time.
Thank you so much, Emma, for such an insightful presentation. I'm hoping that you and Tara are happy to stick around for just a few more minutes. I know your time is precious, but there's a question in the chat for you, Emma, that I think probably a lot of people are wondering about. And that's how many sessions or how long does it usually take for patients to respond to pelvic floor physio?
Yeah, that's a great question. I think we probably have to then determine what respond means. I think we need to onboard patients really quickly, and if they can see a plan in place and some degree of change within the first couple of treatments, they will continue with treatment. In saying that, frequency of treatment is often not, we might be seeing patients once a month over a period of 12 months because we're about embedding habits for patients so that they can then utilize those tools themselves. And if you overwhelm them or give them 100 things to do in the first treatment, they won't do any of them. And we don't, as I said, we also don't want them to rely on us for making them better. So frequency is often less than you'd expect, but and for every patient it's different in terms of timelines, but average, I think we're probably seeing these patients potentially initially for 6 appointments and then wanting them to reduce. So, and that's how we wean them from treatment. We will then reduce their treatments to once every 6 months. And then occasionally I have patients who might check in once every 12 months or if something changes. So.
Perfect. Thank you. I will just open the floor up for anybody who hasn't had a chance to pop their question in the Q&A box. Okie dokie, since we're running slightly over time, and thank you to everybody for staying on for the full session, I might wrap things up if there's no more questions. So I just want to say a big thank you again for everybody who has come and attended tonight, and a very big thank you to both Tara and Emma for such excellent presentations this evening. Just a little reminder for everyone logged in tonight that the Gynecology Services Day is coming up on the 18th of May, which will be between 9 AM and 3 PM for general practitioners. And this is a face-to-face event. So if you'd like some more details, please visit the CHN website And you'll also see details there of our future webinars that we have coming up on a variety of topics. One more final reminder that evaluation surveys will be sent out shortly. So please fill in the post-event evaluation survey so that we can email you a certificate of attendance for tonight. And please feel free to self-report 1.5 hours of educational activities to your CPD home for tonight's event. Resources, presentation slides, and YouTube recordings will be emailed to participants who complete their evaluation. And thank you to Tara, who's also said she's happy for people to reach out via email for resources.
Thanks, Michaela, for hosting us.
My absolute pleasure. And aside from that, that's everything for this evening. So thanks everybody and good night.